So thanks for joining us, and I'd like you to introduce our speakers. Both of them are trusted professionals from Maplewood at Newtown, a senior living community. Christine Marnelakis is a memory care director at Maplewood. Previously, she was the memory care director at Maplewood and Darien. And Christine is a certified dementia practitioner and has a wealth of hands-on experience with cognitive impairments and knowledge of various forms of dementia. And then Melissa Wutke is a lifestyle director at Maplewood at Newtown, and she is certified dementia practitioner, Alzheimer's Association certified community educator, and group support facilitator, as well as an end-of-life doula. So I'm going to turn the program over to Christine and Melissa. Thank you both.
Thank you guys for all attending tonight. It's a pleasure to see all of you. We will be shutting off our camera to be sharing our screen, but at the end you'll see us pop back up.
Thank you so much.
Normal aging and through the eyes of dementia, presented by Christine and Melissa. The myth, everyone gets dementia eventually. Fact, dementia is not a normal part of aging. Your risk increases with age.
So normal aging, cardiovascular changes, veins and arteries stiffen, making the heart work harder to pump blood through them, which is often why older adults have cold extremities, cold hands, cold feet, because your veins and arteries are working really hard to pump all the way to those extremities. So the narrower they get as we get older, the harder it is to pump to those areas. So we'll often see having to wear socks or slippers or gloves, and certainly high blood pressure increases over time.
Changes in your musculoskeletal system, reduce bone density, muscles lose strength. That's why, unfortunately, falls can be so dangerous as you age. With reduced bone density, you're more at risk for breakage and with cracks and fractures. So you have to be very careful to maintain balance and keep yourself, safe as possible.
Changes in the digestive system. Digestion certainly changes over time and slows down. Nutritional intake and medication changes the process. So sometimes when we're put on medications through the aging process, some of those medications can have a negative effect on our digestion. It can make us feel less hungry. It can slow down the digestive process. So we want to be cognizant of that. If you do have a med change, we want to be aware of how our body is reacting all the way around, including digestion. Often for older adults, we recommend having a larger lunch versus dinner, especially those with dementia, because at dinner time, typically those people with dementia are sundowning and they become more confused as the day goes on. So to have them sit for a larger meal and engage during that whole time frame isn't always successful. So we tend to have a larger lunch, which is when they're more cognitively engaged and aware, versus later in the day.
Normal aging, your bladder and urinary tract. Incontinence can happen to anyone. Medical issues that can contribute, diabetes, menopause, enlarged prostate. You do want to give yourself time to make it to the bathroom. It's harder to control our body as we age. That's perfectly normal. It happens to everyone.
Normal aging, changes in memory. It takes longer to know new things. So meeting a new person, learning their name, learning a new task, and it's going to take longer to remember these things.
So dementia is a word we use to describe a set of symptoms that can include memory loss, confusion, problems in thinking, etc. Dementia is the umbrella term for all those things, those other terms we hear, Alzheimer's, Lewy body. Dementia is the umbrella that captures all of those.
So we're going to compare in the next few slides what is a dementia-related change versus normal aging. So I am going to read the dementia portion of the slides, and Melissa will read the normal aging portion. So memory loss that affects daily living. For those with dementia, forgetting names in appointments, asking for the same information over and over again.
Normal aging, you can occasionally forget things and remember later. It's about your recall. Forgetting in the moment isn't necessarily upsetting or concerning. As long as you have the ability to recall, that is what is important. Does anybody have any questions up until this point?
I don't have any questions in the chat either at this time.
Okay.
Okay, your turn.
Okay, problems in planning and solving. So with dementia, we have working with numbers can be certainly overwhelming, following a recipe and paying bills. But if these have always been an issue, then there is no reason to be concerned. If someone who has never really been a chef or a cook or into cooking meals for their loved ones, we can't expect them to follow a recipe successfully. It's going to be a challenge. So we're really comparing who the person was before the disease process started into what their ability levels are now.
Normal aging may include occasional checkbook errors or mathematical errors. Like Christine says, it's about what your baseline is. We are a certain person our whole lives. Myself, I love to cook, but maybe Christine over here does not as comfortable. It's about where we are right now that helps us indicate later on.
Problems with familiar tasks. With dementia, getting lost driving, using a microwave, stove, or phone.
And then obviously, normal aging may include occasionally need help setting the DVR or learning new technology. It's not easy to keep up to date with all the technology. It outgrows us every year. So that's perfectly normal to kind of get lost and frustrated with it.
Time and place disorientation. Trouble with date, season, and time. A lot of times when we ask our loved ones with dementia, if they know the date, they might start looking outside to see if they can get a visual cue of the trees. Maybe there's leaves on the trees, so they know it's fall or it's anything but winter. When the flowers are coming up and they look outside, they know it's spring. So we start to look for our residents giving us those visual cues that they need help and guidance in knowing these day-to-day things that we may take granted for. How did I get here and where are we? I'm sure many people out there get these questions from their loved ones. So we always encourage you to take a step-by-step approach. We cannot give somebody with dementia many steps at once. We're not going to say, we're going to get up, we're going to have breakfast, then we could have pancakes or waffles, and then we're going to go to check the mail, and then we're going to go shopping. That's too much information at once, and they're not going to be as willing to go with you if you were to simply break it down just that we're going to have breakfast. You're giving them a simple goal-oriented task instead of such a large multi-step activity as far as giving them the whole structure of the day. And then live in the moment. We always encourage our caregivers and our staff to live in the moment. If the resident feels as though it's dinner time, but it's only lunch, we're going to join them in their reality. We never take the resident out of their reality. It will only increase confusion. So if a resident thinks it's Christmas or they think it's a certain special day, we're going to go with it. And we're going to encourage that emotion of the day and join them.
And for normal aging, it might include forgetting the day of the week and remembering later. I use my phone all the time to remind me of where we are in this month. You know, days pass by fast, and it's hard to always keep track, even as a normal like normal age progression, what day of the week it is or what date it is. So that being able to use the calendar is indicative of normal aging because you do know how to process that.
Visual changes. There's many sensory changes that we'll talk about this evening. For visual changes that are closely related to the disease process, when reading letters and words may not make sense. So there's something called receptive aphasia. So receptive aphasia is the inability to take in and process what you are seeing visually or hearing. So we often see that. There's also expressive aphasia that we could talk about in the next slide. And changes in depth perception. You'll see your loved one often maybe walk their walker or rollator into the corner of the wall or hit it against the hallway or a table. That's really because their depth perception is so vastly impaired. It's not necessarily that they don't see the table, they just think they have maybe 2 feet when they're a lot closer than what they may think.
And normal aging, it may include some visual changes caused by other medical diagnoses, such as macular degeneration. Losing the full ability of your eyes can be very normal. You know, it runs in our genes. It's not always determined by us, but it does not necessarily have anything to do with dementia. However, as Christine said, it can make the dementia process harder. Does anybody have questions yet, Elaine?
Just a question about the materials. Will you be able to get them to the participants at some point, or can we, if you give them to me, I can email them out to everyone who participated tonight?
Yes, I'm sure we could send over some form of communication of all this information.
That would be great. Thank you.
You're welcome. Okay.
Problems with speaking and writing in regards to dementia. So train of thought is easily lost, and a person with dementia does not know how to continue. So as they're trying to form a sentence, they have to go into their brain, go to their filing cabinet, which is their hippocampus, look for the file in that cabinet of what they want to relate to you, and dig through there. So in that time frame, it takes at least 30 seconds for someone to be able to complete that task and form a sentence if they have dementia. So oftentimes someone will feel that pressure of needing to finish the sentence, and then they'll lose train of thought. So we need to give that person at least 30 seconds to complete that thought, dig through their hippocampus, give us the information they need, and then they can form the most relatable sentence. We have a story within Maplewood that we had a resident who would have breakfast every morning with their loved one, and his wife would say, "I love you," at the end of breakfast, and then she would leave because he wasn't responding in the time frame she thought was appropriate. Later on, we let her know that he does say "I love you," but unfortunately, you're already out of the building. So in knowing that, she stayed a lot longer, and he was able to say "I love you" back to her. So in giving that time, you're able to maintain that emotional bond that you have with your loved one. So just keep that in mind when you are spending time with them. They may be inserting the wrong word. So they might use salt instead of pepper. They might use closed instead of open, cold instead of hot. So we just want to be helpful and aware of their surroundings and what they might want to be communicating. And appears to write and only in scribble. So if you look at someone's handwriting with dementia, they may be scribbling, but sometimes it's also the amount of scribbles actually equals the amount of letters in the word. So maybe they're spelling cat and there's 3 scribbles. So they know what they want to say and they're just unable to process that. So in the last slide, we talked about receptive aphasia. So expressive aphasia is the same idea. They're unable to come out with what they want to come out with. They're able to process what you're saying. In their mind, they are able to form an appropriate response, but the connection to their mouth is not there any longer. So sometimes giving them that a lot of time is helpful, but sometimes that expressive aphasia can overtake communication.
In normal aging, as Christine said, you might have problems like finding the right word, and eventually you will find it. A lot of times, I'm sure a lot of you are sitting thinking like, "Oh my goodness, is this a sign?" But sometimes when your brain is working, we do substitute a similar word for another word. As Christine alluded to, it will be a wrong word in place of another word. But if you're using descriptive words and you find another word that's similar to it, that is okay. That's your brain still making those connections.
Misplacing things, cannot retrace steps to find an item, hiding things or putting things in unusual places.
Normal aging may include occasionally misplacing items and finding them later. I have a habit of this, putting things where I think they'll be the safest and they're safe even for myself. But the most important thing is being able to retrace your steps from the whole day and remembering where you have been.
Poor judgment or decision-making skills. There's certainly a financial component to taking care of somebody with dementia. They're much more vulnerable to people who don't have the best intent, or even over donating is something that I've experienced with my grandma who has dementia. She, is at the emotional level, not necessarily the cognitive state anymore. So she often will see an advertisement on television to donate here, donate there. And she's quick to pick up the phone and be helpful, but she doesn't remember just donating recently. And she's unable to keep track of what she's doing financially. So that is something sometimes caregivers can overlook, that financial component and being their advocate. not only in the health perspective, but in the financial as well. Personal, so poor hygiene, and does not recognize the need for hygiene.
Normal aging may include the occasional bad decision. Nobody here is perfect. You know, we might make a poor error in judgment. That does not necessarily mean there's cause for concern. You might make a risky gamble or investment, but if it's more the occasional versus the consistent.
Social withdrawal in relation to dementia. Someone who has just began the disease process may feel embarrassed because they still have that cognitive awareness to know that they are not able to keep up with their peers. So they may feel embarrassed. As a result, they may become more reclusive, trouble keeping up with activity and conversation. So if we're able to bounce from one thing to another, they're unable to keep up with us. So we want to make sure we're cognizant of that and maybe, wrap up one topic with kind of an ending sentence. So that way they know this is a close of one conversation starting with another. Consistently overwhelmed and stressed. So there's a lot of sensory components to dementia that we will talk about shortly. But to manage all those sensory changes can be so overwhelming for somebody with dementia. So that's really where being overwhelmed and stressed comes from. Not able to process and manage all the different elements of an environment that they need to.
And then with normal aging, it may include occasional feelings of overwhelmedness from social or family gatherings. There's a lot that can be happening in those family gatherings. It can be overwhelming to anybody. It's when it's, again, consistently, not like, oh, I don't want to go to this wedding because there's going to be 250 people there. It's for everything that might be 4 or more people because it's too much to process, too many conversations to keep up with. Elaine, do we have any questions?
We do not have any new questions.
Okay, thank you.
You're welcome.
Changes in mood or personality in relation to dementia. Someone may feel suspicious, afraid, depressed, or confused. So, of course, that goes along with the sensory components that are changing and increasingly irritable. We often ask our staff and caregivers to rephrase their sentences to start with a positive. So if we are with our loved ones and we know that they're sitting in an unstable chair without arms, whatever it may be, we often will say, no, don't sit there. And now we're startling them. They're becoming suspicious of what is the problem, just trying to sit, and may increase confusion. Instead, we might want to start the sentence with, hey, Dad, I think this might be a better chair for you. You'll have a nice view from the outside. Whatever it may be, we want to make sure we're starting with a positive instead of startling them with a negative.
In normal aging, it is normal to become irritable when an established routine is interrupted. It may be that, every Sunday you have a set plan, and when you have to deviate from that plan, that is irritating. That's irritating for anybody when you have a plan in your mind.
80% of risk factors are controllable. So we want to avoid alcoholic beverages. So too much alcohol intake can often cause confusion and memory loss. So we always work with our residents and maintain that cultural component of who the person was before the disease process. If they had a glass of wine with their family at every meal, we certainly don't want to stop that. However, we do implement non-alcoholic wine so that way it is safe. And also, not everyone's always aware if any medication they're on may be contraindicated with having alcohol. So we never want to incorporate that if we could use non-alcoholic wine instead. We also want to encourage quitting smoking. Some studies have linked middle-aged smoking to increased risk for dementia.
80% of risk factors are controllable. You want to eat a healthy, balanced diet. That does not mean giving up all your sweets, but everything is a balance. If you want to have ice cream for lunch, you can't have ice cream for lunch every day, unfortunately. That's the dream world where I live too. But you want to have a heart-healthy diet because it can lead to your brain health as well. And then you want to have exercise. Exercise increases blood flow to the whole body, including the brain. Everything from small exercise to large exercise. You want to use your fingers, your toes, your whole body systems. That's good for not just your body, but for your brain, your neural connectivity.
More ways to reduce the risk. We want to stay social. Always keep your mind active with your peers and with families. Do mentally and cognitively stimulating programming. So watching TV or watching the news may be interesting and keep engagement. However, is it the most stimulating program?
So we're going to do a normal aging versus dementia recap. Dementia is not a normal part of aging. However, risk of having dementia does increase with age. So what is normal as we age? Cardiovascular changes, musculoskeletal system changes, digestive changes, changes in continence, and some changes in memory, like more difficult to remember names of people we just met, more difficult to remember particular words, takes more time to recall recent things from memory, more difficult to multitask, and memory slip-ups are more common.
What is not normal as we age and should be reported to a physician? Memory loss that affects daily living. So we all know how to use a microwave. However, if someone maybe puts their metal coffee cup in the microwave now, that is a risk behavior related to dementia that we would want to notify a physician. Problems in planning and solving issues, problems with familiar tasks, time and place disorientation. This is often common with dementia when they say you bring your loved one back to their home and they no longer recognize it because it may be a new home or a short-term memory where they're picturing their home as their childhood home. So anything that is more short-term, the past 20 years, 30 years, are kind of considered short-term in relation to if someone's in their 80s or 90s. And then we look at long-term as in their teens, 20s, and 30s is what we're most likely seeing our residents relate to. So if they don't recognize their home, if they don't recognize their grandchildren versus their children, they're all long-term memory. Problems with speaking and writing, misplacing, losing the ability to retrace steps to find them, poor judgment and decision-making skills, and social withdrawal. Layers of challenges, normal age-related changes, sensory challenges, cognitive deficits, all result to a new reality.
Challenges facing older adults. Physical changes, bones. Your bone marrow gradually disappears, leading to reduction in bone mass. Older adult bones can brittle, making them susceptible to falls. Hair loss and graying, that affects your self-confidence. Height, people do lose 1 to 2 inches in height. Muscles, reduction in strength due to a loss of muscle tissue. Older Americans have to be careful not to overdo it. Skin, age spots, wrinkles, sagging skin. Skin becomes less resistant to cuts and bruises. Teeth become more sensitive as we age. Tooth decay, gum disease, and teeth discoloration occur with age. Chewing and tasting food can become challenging. Weight, past age 50, reduction of fat. As we age, because we might not have the same hunger we used to, weight loss is very common, especially in our folks who have any kind of cognitive loss. Yep. Hearing impairment, often mild or moderate, but 48% of men and 37% of women over 75 experience hearing difficulties. That can also impact how we hear things, what we're processing. Hearing has a big part in if people come across as having memory loss or not. Oftentimes people who can't hear seem a little bit more lost and confused than they are. Visual changes, problems with reading speed, seeing in dim light, reading small print, and locating objects. Response time to the environment slows, and need for assistance with everyday activities increase. We can't bend the way we used to. We can't quite be as limber or as nimble.
One thing I do want to jump on was the height that Melissa mentioned. It says people may lose 1 to 2 inches in height. It's a misconception that it's often maybe your bone density decreasing. It's actually the intervertebral discs within your vertebrae in your spine that lessens and lessens. And that is really making the height changes. It's not change in bone density. It's that intervertebral discs that shrink or lessen. Sensory changes as a result of dementia. The impact on the 5 senses. What does dementia do to our senses? With sight, visual and spatial perception issues, and peripheral vision is affected. So peripheral vision is what we see on our sides. When we're able to realize that somebody's coming up to us on our left or right, That's our peripheral vision. So if you make a circle with your fingers and place them in front of your eyes, that is what somebody with dementia, specifically more so Alzheimer's, sees. They really develop that tunnel vision. So when we're approaching somebody with dementia, more so specifically Alzheimer's dementia, we want to always approach from the front because their vision is so vastly impaired. With smell, often the first to be affected by dementia, smell helps us to identify things, of course. With taste, the loss of smell plus the added decrease in taste bud sensitivity can really affect the way a person with dementia tastes things. So with taste, we often utilize any sugar that may be used, maybe a little bit of sugar on eggs to help them want to eat that protein. We know through studies that the sweet taste buds and a sweet taste is what people with all forms of dementia really crave for and what they're really able to taste last. So they'll lose all their other taste buds, but those sweet taste buds still hang in there. We often recommend maybe putting applesauce over a protein, maybe a chicken, things like that. So that way they're more apt to eat that protein because it has a sweet taste to it and they can really taste it. With hearing, as in the case of the eyes, a person could test as having perfect hearing, but not be able to process sounds. This can lead to agitation, confusion, or overstimulation. So the first thing our loved ones do will take out their hearing aids, right? How many people out there have a loved one with one hearing aid or no hearing aids because they're gone? There's definitely a market out there for someone to invent a GPS that will be put in hearing aids. I hope to see that on Shark Tank soon, so that way we could all benefit from that. So definitely hearing is greatly affected. You'll see them taking out their hearing aids if they are overstimulated, if there's too much going on in the environment. For touch, depending on how severe the loss is, a person with dementia may not be able to recognize being cold or hot or even being in pain. So often we will make sure that we are putting our hands in the water of a shower first, because they may not be able to express if it's too hot or too cold, or really even feel it if it's too hot, and then it's already too late, they're burnt. So they're losing those sensory receptors to touch and are unable to have that thermal input. As with all other of the senses, sensitivity in touch decreases.
Elaine, do you have questions?
No, we don't have any questions at this time.
Okay, thank you.
You're welcome.
So skills and abilities affected by Alzheimer's disease. Memory. Recent events are affected by short-term memory. Long-term memories remain late into the disease. So as Christine was saying earlier, oftentimes those short-term memories, those things that we just have learned, do not stay with our friends with dementia. Long-term memories stay longer. That's why you have people who can recall where they went to high school and they live in that time frame. Vision. Impaired objects look flat. So you can go up to an object and it can look flat to the person with dementia. They may not be able to visually perceive that it is a three-dimensional object. They're unable to judge distance appropriately. As Christina talked about earlier, when they're navigating around furniture, they might think they're closer or farther than they really are from the furniture. That's why, unfortunately, for a lot of our friends with dementia, we need softer edges for furniture. Peripheral vision is impaired. They may see just what is in front of them. They do get very tunnel visioned. Language, trouble finding words, problems understanding verbal requests. You can ask them something as simple as "How are you?" and that can be sometimes very hard for them to even grasp.
Alzheimer's and dementia affects the following skills and abilities. So movement, struggling with fine motor skills. I think everybody knows what fine motor skills are. That's everything related to your hands. So we often relate that directly to buttoning a shirt or zippering a coat, but also is relative to eating. Because if they're unable to have the strong enough fine motor skills to hold utensils and operate them, we're gonna have a decrease in appetite, maybe even behaviors, and really decrease in engagement during those meal times. So they might say, no, I'm not hungry, it's okay, but what is a real problem? Could it be that they're unable to utilize utensils appropriately and maybe would benefit from a change in diet to finger foods, a sandwich, things that they're able to pick up without using utensils? Coordinating vision and movement together can become difficult. Ultimately, as the disease progresses, they will lose the ability to walk. Tasks with multiple steps are hard for them to complete, and emotions lose the ability to control their emotions. Poor insight, lack of insight or memory about their disease. So a lot of loved ones will ask, how come I'm here? How come I have to be here? That's really just their lack of self-awareness and where they are in the disease process, and or even not understanding how it affects their safety in the day-to-day. So of course we never want to point out our loved ones' deficits and impairments secondary to the disease process, but we just want to be able to provide a concrete answer that is going to carry out for everybody who's taking care of them.
As Christine said earlier, you want to start with a positive emotion. So a lot of times they'll say like, am I sick? Why can't I come home with you? Instead of highlighting, oh, you are sick, or oh, I can't take care of you. Just feel like wherever they are is the safest place for them. Or if they're being taken care of by a caregiver, like that's the person they've been chosen for safekeeping. They can't comprehend what's truly going on around them.
Also possible with Alzheimer's and related dementias are delusions, hallucinations, and paranoia. So I'm going to break those three things down. So delusions are a thought that isn't based on reality. It could be that your loved one walking into a restaurant and they think they own the restaurant. They might even get up and try to go into the kitchen to check on the chefs. That's a delusion. A hallucination is anything that incorporates a sensory component. So they can hear voices, they could see, a cat on the floor that's not there. They might see someone in their room that's not there. And then paranoia is often a accusatory behavior where you took my pocketbook, you're hurting me, you want me to go here. It's often a accusatory leading behavior versus a delusion or a hallucination, which is kind of just a chemical imbalance of creating them to think or see something. There's also aggression and sexually inappropriate behavior.
And I do want to say one thing. So it does say aggression. Agitation is also something that is increased, and agitation and aggression are not the same things. Aggression is usually outward emotion. Like aggression will be me to Christine, taking out that frustration, fear. Agitation is most often internal, but that can lead to aggression. So what if our morning started with your hot water tank is broke, so you have a cold shower. You go into the shower, you're expecting that nice hot water, wake up, and all of a sudden freezing cold water comes streaming down at you. Car accidents, so you're late to work. You have additional work thrown at you. We all have a rhythm to our day. As these different things are thrown at you, how would you feel? How do these events make you feel? How do you control your emotions? We want to walk in the shoes of someone with dementia. How would you feel if you're walking and all of a sudden somebody is talking so loudly and fast at you? As Christine was talking about earlier, they can't always see us coming, and so that surprise element would make anybody uncomfortable.
How would you feel when you bathe? I think most of us agree this is one of the hardest things to complete with your loved ones. It's just such a vulnerable situation for them to be in. And it's what they're most fearful of. So how may someone with Alzheimer's or dementia feel when they bathe? A person with dementia may not recognize that they now need assistance, may not realize they have been incontinent, they feel embarrassed or uncomfortable. Changes in vision can make a bathroom scary. Bathroom temperatures may not be adequate for them. Water temperature may be too hot or too cold due to the changes within their skin. Person doesn't like the feel of water. Multiple steps can be frightening to them and difficult to do. Person is afraid they will fall due to wet, slippery surfaces.
So as Christine said, bath time is often the most hard time. The other thing I wanted to say is, how often do we really take a shower with somebody? After a certain age, nobody bathes you, you shower alone. So all of a sudden have somebody be there to shower you can be embarrassing, can be very uncomfortable, especially as you get older, you are more modest, you're more, embarrassed of what your body looks like. You're not really comfortable with everything going on with yourself. So residents with dementia may be unable to focus on the task at hand, forget in mid-sentence what they're talking about, or have difficulty answering questions. Too many choices becomes overwhelming to them. This is something Christine and I talk about a lot, is you gotta narrow it down to 2 or 3 options at most. Sometimes even with clothes, I don't show an outfit to some of our friends with dementia because that can be overwhelming. So I'll say, what color do you feel like today, red or blue? Unable to complete routine tasks such as dinner time or family visits. They get lost easily, wander, exit seek, and they display recurring behaviors. So I want you guys to look at these signs, and I want you to think about how you would follow these signs. Can you follow these signs? They're not clear. That's often how our friends with dementia feel for signs that we see as everyday ordinary signs. For somebody who does not have dementia, we might only see, for the picture on the left, the top sign, but our friends with dementia might see both signs, so they're not sure what to do or where to go.
So how would you feel if you were in this situation? So we have a lot of people, all of their faces are covered, which unfortunately is what our residents are dealing with now, as we all have face masks on. Large group, they're all in uniform. It's a very sterile environment, so it can be very overwhelming when you're not given the information needed. How might someone with dementia feel here? So you see it's very overcrowded. There's a lot of people. You can almost hear the picture, the hustle and bustle of everyone talking, maybe cars that are trying to get through. This is what our residents feel like, maybe just in a restaurant, that overwhelming sensory environment.
How do you feel in this bedroom? When I'm looking at this picture, it's incredibly dark. How do you navigate around that bedroom? There's a lot of stuff going on. There's a lot of clutter. How do you get to the bathroom in the middle of the night? What do those shapes look like with the shadowing? It's very hard to tell what's going on in this bedroom. And for somebody with dementia who can't even process that there's a chair and a lamp, it could look like people. Any questions so far, Elaine? We're still good?
We do have a few questions.
Okay, good.
The first one is, are there any reasons why some people may progress faster than others when signs of dementia are present?
So we often see dementia progressing faster in younger ages of diagnosis. So someone who's diagnosed in their 60s, early 70s may progress faster than those in their 80s and 90s. So age often, not always, but often plays a component in the progression of the disease process. If there are any risk factors prior to the dementia diagnosis, how healthy they were prior, how active they were prior, and how active they're able to still be in maintaining blood flow to the brain. If they had any recreational activities that may have affected cognition, drug use, alcohol use, whatever it may be, also play a role in the progression of dementia. And if someone does get dementia, there is actually a specific form of dementia related to alcohol use. So those are the ones that pop directly to my head. Melissa?
For me, what pops into my head is, unfortunately, no two dementia journeys are the same. Everybody is going to go through the process differently. And there's a saying in the dementia world is, when you've met a person with dementia, you've met one person with dementia. So although a lot of our skill sets and a lot of our knowledge is applicable, everybody is truly on their own journey. And what works for one person might work for 3 months, 6 months, and it's constant, fight to just make the process as easy as possible. That's what we're all here for, is just to make that process as manageable for them, and also as caregivers for the caregivers as well.
I'll add one thing: the faster we're able to recognize the dementia starting, the better, and the quicker we're able to get your loved ones seen by a neurologist or psychiatrist, the better. So that way they can start on medications that can slow the disease process. A lot of times doctors will not recommend medication use when they're at a certain stage in the disease process, and we've kind of missed that window to slow it as best we can. So you want to make sure as soon as you may think that someone may be getting the disease process, you want to make sure we're implementing any medications that can help slow it.
Thank you. Another question is early onset Alzheimer's dementia versus typical dementia. What are the differences? And any comments?
So typical Alzheimer's does progress a lot more slowly than a lot of our other dementias. People with typical Alzheimer's can have it for years before anybody truly can even recognize it, because they are staying within their same scope of behaviors. I've known people who are like, oh yeah, my mom probably had it about 5 to 10 years ago. And that can be very true of a typical Alzheimer's process. For early onset, it's usually much quicker than its counterpart, but does still move through those phases, just at a different pace. Christine?
Absolutely. No, absolutely. Spot on. They certainly do go through all the stages of dementia, just at a faster pace. We often see frontal temporal dementia set in with the younger age range, as well as vascular dementia that's often secondary to a stroke or CVA. Those are the two that we typically see in early age. Not that others can't be, but most commonly those are the two.
And what about Lewy body dementia? Any differences there, and how to manage that?
Yes, so Lewy body is a horse of a different color. So Lewy body is different in that medications that traditionally work for most of our friends with dementia have the adverse opposite impact on the Lewy body person. So what works for one does not work for Lewy bodies, and it is different. Sometimes night is day and day is night. There is a lot that you can still do for the person with Lewy bodies.
Just more specified on what would benefit. In my experience, I also see there being more behaviors in relation to Lewy body versus, say, Alzheimer's. Alzheimer's is typically memory loss, confusion. Lewy body, maybe there's hallucinations, general more agitation, and memory is not really affected. So they might remember you day to day. However, that's not going to stop any frustrations or agitations or behaviors that they may have being put towards you. So there's a higher behavioral component to Lewy body.
With frontal temporal and with Lewy body, oftentimes, Christine and I've seen that memory doesn't get as impacted until much farther in the disease process, because Lewy body and frontal temporal affect different parts of your brain than typical Alzheimer's.
And can people have a mix of dementias?
Yes. So people can have multiple dementia. So it is called mixed dementia. You could have 2 or 3, and that's when you have to try to find as many common grounds. But if you have 2, then what works for just traditional Alzheimer's or traditional Lewy bodies does not work for mixed. And that's why all the research that's being put in to our many forms of dementia by the Alzheimer's Association, all those other work to figure out what is working, what is not, and finding a gerontologist and a neurologist to help work with your loved one is very helpful.
Great, thank you. One last question, I think. Is there a test now to determine if you are likely to get or have markers for dementia? If your parents have dementia, are you more likely to get dementia?
Yes, so certainly there are tests out there. If you have a loved one who does have dementia, you are at a higher risk of developing a form of dementia because there is a strong genetic component. There is certain blood work that can be done to look for certain a chemical imbalance that may be prevalent. I'm losing the name of the test at the moment. There's also a smell test that is kind of still in the air and a bit dicey, not necessarily scientifically strong yet, but they're working on that smell test that, as we know, smell is the first sense that we lose when we have dementia. So they are working on that as well.
I recommend for anybody who does have a loved one with dementia, when they get afraid that it could impact them, obviously nobody here can fight their genetics, but there's a lot of things you can do to reduce that risk, even though you are at a higher risk with your genetic precursors. Like we talked about, the diet, playing brain games, challenging yourself, taking on new experiences. Your brain is a muscle. So just like when you're weightlifting and you want to go up to the next set of weights, you want to do the same thing with your head. You want to go up a level. So maybe you're always doing an easy crossword. Go to a medium, go to a hard, challenge yourself to come out of your box as much as possible, because you want to flex all the muscles in your brain as often as possible.
Thank you.
Okay, so do personal preferences really matter to everyone? What preferences do you have with following care items? Bathing. Do you like to shower? Do you like to take a bath? Hair care. How do you like your hair combed, brushed? Do you like it put up? Eating. Do you like Italian? Do you like Chinese? Dressing. Are you more of a casual dresser or a formal dresser? Sleeping. Do you like to sleep on your couch, on your bed? I know all of that sounds so silly, but when you put those things in place for somebody with dementia, it can make the experience so much better, because we are identifying the person in the dementia disease versus them as a patient or as a clinical term. You know, as Christina and we've been talking about residents, languaging like that is so important, because we remember the person inside the disease process.
So additional preferences that you may want to take into consideration when working with your loved one: favorite activities, how they enjoyed spending their time. If at the moment you want to spend more quality time with your loved one, we want to make sure we're doing what they've always enjoyed doing and what they're used to create a less challenging experience, and we'll create more of an open dialogue if they're not so hesitant and concentrating on a new task. Personal habits and daily routines, favorite type of music, favorite type of food and drink, preferred colors, are they a morning person or a night owl?
Individual and personal preferences are important. You want to create an environment where their preferences are acknowledged and it helps them feel relaxed and comfortable. They feel they have some control over what is happening. They feel their wishes are being respected, and care then turns into a pleasant experience. If you go into a bathroom and we know that you like the floor to feel warm, or you like a rug and that's happening, then they're not going to be as resistive to what's happening in that bathroom.
Tips to help us learn about the individual. Always start by asking the person. We never want to assume, because a person with dementia is ever changing. What their short-term memory was of what they enjoyed later in life is no longer their reality. They revert back to long-term memory. So we do want to ask them what they would like to do. We never want to speak for the person and think we know who they are in that moment. Keep questions simple. So we don't want to bombard them with many questions, one question at a time. It's even more appropriate to ask yes or no questions, because it will take the stress off of your loved one, and they will be able and more willing to have a dialogue with you. Other ideas: talk with family members, talk with other staff, look at care plan or social history, look at things around their room or home, pay attention to what they like and don't like.
Their past is important. Were they married? Were they single? Did they have children, siblings? Do they like animals? You know, a lot of times, oftentimes people will tell me, oh, bring an animal to my mom or dad, and then I'll try to do that, and their mom and dad will be like, I don't like dogs, or I'm afraid of them, not thinking about who their mom or dad has been this whole time. Social and work history, homemaker. Did they work outside the house? Did they take care of somebody their whole time? Where did they grow up? How did they grow up? Religion, spirituality, hobbies and interests, all of that couples together to make the experience as comfortable as possible.
Their abilities are important. Physical abilities. What care tasks can they still assist with? If they're able to sew their arms through a shirt, but they can't do the buttons, allow them to do what they can. We try not to do everything for the person, because if you don't use it, you lose it. That includes walking, that includes participating in activities and getting dressed. Can they walk? Can they move easily? So when you bring your loved one out to a restaurant or to a mall or whatever it may be, take that into consideration. How able are they to move easily? If they're not, you might want to call the restaurant ahead of time to make sure that they have a ramp. You may want to call ahead of time to make sure that you're close to the bathroom or the door. Do they have visual or hearing impairments? Cognitive abilities, how do they communicate with us? Their wants or wishes? Is their short-term memory intact? Do they suffer from hallucinations, delusions, or paranoia? Can they follow simple steps?
As Christine was saying too, you always want to just try to find a little win in their day, because a little win can go a long way. We want to share what we know. We want to share care information with others. We want to use information that's shared by all. We want to improve their care planning and build team partnerships. So if I could tell you 10 things a person with dementia would tell you if they could.
Number 1, you know what makes me safe, secure, and happy? A smile. Did you ever consider this? When you get tense and uptight, it makes me feel tense and uptight. Instead of getting all bent out of shape when I do something that seems perfectly normal to me and perfectly nice to you, why not just smile at me? It will take the edge off the situation all the way around. Number 4, please try to understand and remember it is my short-term memory, my right now memory that is gone. Don't talk so fast or use so many words. You know what I'm going to say if you go off into a long-winded explanation on why we should do something. I'm going to say no, because I can never be certain if you were asking me to do something I like or drink a bottle of castor oil. So I just say no to be safe.
Slow down and don't sneak up on me and start talking. Didn't I tell you I like smiles? Make sure you have my attention before you start blabbering away. What is going to happen if you start blabbering away and you don't have my attention or confuse me? I'm going to say no. Count on it. My attention span and ability to pay attention are not as good as they once were. Please make eye contact with me before you start talking. A nice smile always gets my attention. Did I mention that before? Sometimes you talk to me like I am a child. How would you like if I did that to you? Think about this. Don't tell me you are sorry. I won't know what you're talking about. Just stop doing it and we will get along very well and probably better than you think. You talk too much. Instead, try taking my hand and leading the way. I need a guide, not a person to nag me all the time.
Some caregiver resources, you could always go to the Alzheimer Association at that website, call them, and they always have 24/7 live support. I've utilized their line often, if just as a second opinion and ideas of what to do and what would be a good approach. And Dementia Caregiver Support Group, Maplewood at Newtown hosts it, Melissa and I, the second Wednesday of each month from 6 to 7.
Right now it's virtual. It's through Zoom, 1 to 2 p.m. But going back, hopefully post-COVID, it will be live and in person. We do want to invite you to take a virtual tour here in our facility July 9th at 2 p.m. You can call or RSVP through those. Christine here also runs a dementia boot camp. She's got 5 more sessions ahead of her. So if you want to sign up and learn even more in depth, we're going to take some questions, but I do want to let you guys know that is a resource as well. So we're going to open up our chat and stop sharing our screen so we can go to questions.
Great. And we do have a few questions in just a couple more minutes. So let's see. Someone suspects that their mom may have had the start of dementia. She does not realize anything is different. I met with her PCP and suggested a consult with a neurologist. We had an appointment this week and she canceled it. How can I get her to realize it is necessary? I told her we would revisit it when she could handle it.
So what I would tell you, Christina, to tell your mom is maybe don't make it about the possibility of dementia. That can be very scary and overwhelming, but maybe ask your mom to do it as a favor to you, just as a check-in, and then also see if you can help with scheduling the appointment, so it's not directly in her hands. You never want to pressure, but I think she also needs to understand how important it is to you. And, you know, she may have difficulty accepting it. So like I said, if you kind of play up, I was like, Mom, you know, I could be wrong. It would make me feel better to just have you talk to somebody, do this check-in. You know, we'll face it together as a team, whatever's going on.
Yeah, definitely. I agree with Melissa, allowing some ownership and open conversation. I think having a conversation of what are you fearful of, allowing your loved one to know that you're going to meet them at the emotional level, and that you're allowing them to own a little bit of it. I also think it's also the PCP's responsibility to make sure there's a clear understanding of the reason for the neurologist to take that pressure off of yourself. I feel it is his duty as her PCP to have that conversation. I don't feel that it has to be on you. So I often recommend that families have that conversation with the PCP on why he thinks. So because that way you're taking yourself out of the conversation. It's how you think. It's what the medical professionals also are thinking is in their best interest.
And do you see there's another question there? My mother is resistant to help that I think is needed. She will not share information about her medication or let my sister and I into her home to check on safety issues. How do I legally and lovingly approach her PCP with concerns?
Well, I think you can call her PCP and they can kind of guide you through what they will and won't share. But if the PCP has the same concerns, then they can also partner with you to make the necessary adjustments for the safety of your mom. Because if she does need help or there are some concerning things, I believe, like Christine, that it's also on the PCP's radar and mind. So I think it does not hurt to call or reach out to the PCP and say, I know obviously HIPAA, you cannot share if my mom has not put me on the list, but this is above and beyond about her privacy. I just need to know if we believe that there are any safety concerns at this time, because they do have a legal obligation to make sure your mom is as safe as possible.
Thank you. Do you see, I know it's a little after 8:30, but we do have one last question there, and it's relating to COVID.
Yes, do you have any suggestion about this time of COVID? Any of the activities and joy they can't do, they're stuck at home and feeling sad. How do you redirect them?
So Melissa, as a lifestyle director, is working endlessly for our community to provide stimulating and relative activities for our residents. So it's going back to knowing the person as the individual and where they are now in the disease process, right? So if they have a short-term memory interest, that may not be an interest anymore. So going through family photo albums, listening to certain music that they enjoy. We always want to meet them at the sensory level too. So if there's any certain food that they like that can really spark some energy in them. So we want to make sure that what we're doing is really of interest to them now, and it's within their capacity, as well as introducing music or anything like that in the sensory world that they would enjoy.
I think also, so there's a couple of suggestions I have for you. First of all, you know, a lot of us, I'm sure, during this COVID time are cleaning out the house. I think without necessarily indicating to them that you're cleaning out the house, but, you know, have them sort laundry if it's, especially our mothers of this age, you know, they're homemakers. So having them sort through clothes and being like, Mom, we don't need size this or that, because that again goes into the tactile and into the sensory. Having them sort sometimes beads, different items like that. A large print book, for a lot of my friends with dementia, although they may be rereading it, it's very comforting, it's soothing. Like Christine said with the music, exercise is incredibly important. There's a lot of great resources out there. We do exercise of some kind every day in many different ways. Sometimes we use water bottles as weights because we want to be using all of those body muscles to be keeping those neurological connections still going.
I would also recommend if your loved one has grandchildren or even with you as children, maybe a pen pal type of communication at the moment with COVID. And if they're unable to write, even if it's exchange of picture drawings or art.
Yeah, adult coloring is incredibly important. And they can make that adult coloring page into like a postcard for a friend or for a grandchild.
Thank you both. This has been wonderful. You are a wealth of information, and we appreciate you sharing it with us.
And thank you guys all for attending. And if anybody has any other questions, you can reach out to the community. We both, as Christine and as Elaine had mentioned, we're both certified dementia practitioners, so we deal with this on the ground every day. And everybody needs support. We're all, in this together as one community.
Yes, thank you all for joining. You're all taking a huge, big step in reaching out and gaining some knowledge on the disease process and how to best assist your loved ones. So by all means, we really appreciate you joining us.